Hi everyone, my name's Caitlin and I am the PACOP Improvement Facilitator up in Queensland, and today on our PACOP Clinical Bites we will be going through the symptom assessment scale for care workers, specifically around distress from nausea and what that means and how we assess it. So nausea is the unpleasant sensation of being about to vomit. We've all had that feeling. It's a very normal human response of feeling really queasy and sick and feeling like you want to vomit. Now, not all people who have palliative care needs will experience nausea. Nausea can either be acute or chronic, and it's not sometimes always associated with vomiting either. You can feel nauseated without wanting or having to fully vomit. In many cases, it is possible to identify the cause for feeling nauseated, although in the palliative care population, nausea is frequently multifactorial, so there are normally many layers in the palliative care space why a patient or a resident may feel nauseated. Factors that can cause nausea include abdominal and gastrointestinal cancers, sometimes bowel obstructions, constipation, cancer that has affected the central nervous system, liver failure, sepsis, reflux, or sometimes it can just be a side effect of medication as to why someone is feeling nauseated. Now, there is no widely accepted objective assessment tool for measuring nausea and vomiting in palliative care other than the symptom assessment scale. Because nausea is something that must be self-assessed by a patient or a resident, us as care workers and nurses and healthcare professionals, we can't actually feel how sick or how nauseated someone feels. We've got to rely on that feedback from our residents, and we have to find a way of measuring that and assessing that. Whereas vomiting can be monitored objectively. We can see when someone vomits, whereas nausea is not something we can actually see. So when we use the symptom assessment scale, we are assessing the distress of any particular symptom on the symptom assessment scale list over the past 24 hours. So if we have the tools that you can see there on the slide, the resident brochure, the SAS rulers that we provide to take around on medication trolleys, these tools can really help guide the conversation for us to understand from the resident's point of view how bothered they are about that particular symptom, and that symptom that we're focusing on now is nausea. So using those tools, we can sit alongside a resident and give them the opportunity to point out how distressed or how bothered they are about feeling nauseated, if in fact they are feeling nauseated. Now, the key word that I used there was distress. So distress refers to the emotional or psychological discomfort and suffering experienced by an individual due to their symptoms in a particular situation. So it's subjective and can vary from person to person. So we're not talking about the severity, we're not talking about how severe the nausea is out of 0 to 10 or on that colour scale or FACES scale. We're asking how distressed or how much does the nausea bother you. So that's a subjective point and can vary from person to person. What one person finds distressing, another might not. Just because someone has nausea or has that symptom doesn't mean that they're necessarily that bothered by it. It takes into account the emotional impact of symptoms as well as a person's overall well-being and quality of life. So distress is often assessed through a self-reported measure and interviews and discussions. So you can see here on the slide, we have an example about how we can maybe weave a chat about distress and nausea into a discussion. So perhaps around meal times, when you're setting someone up to have their meal at the table, or you're helping them with their food and a bedside table in their rooms, talking about how they're feeling, because particularly around that time of day at mealtime, the smells and the sensations of food and the texture of food may elicit that reaction or that symptom in someone around feeling nauseated. So use those moments while you're busy setting someone up or helping them with their meal to dig a little bit deeper and see how they're actually feeling around their nausea and whether they're necessarily distressed by it or not. So one thing we get asked all the time is how you use a SAS when someone can't speak or when someone can't articulate how they feel. So you can proxy score for someone. So if you know the resident really well and know what their usual behaviours are like, you might want to ask yourself, are they presenting any different today? If you don't know the resident, ask someone who does, whether that be a family, friend or a co-worker. And finally, the SAS score guide for nausea problems you can see down the bottom of this slide and is also on the back of the daily SAS tool. So our take-home message today is use the 3 R's. Record, have your ruler nearby, and report to your supervising RN as per the ruler. If one of your residents has reported to you a mild level of distress around nausea, report to them within the shift. If someone has reported moderate distress around nausea, report within 30 minutes to your RN. And if you have a resident that has severe distress around their nausea, you need to be reporting it immediately. Thanks everyone for watching. This is part of a greater series that is called Clinical Bites for care workers. For more detailed information on all the PACOP assessment tools, make sure you find your local PACOP lead at your aged care home or send us an email at pacop@uow.edu.au.